Dr. Lavanya, what you do is, if you have a Windows laptop, you try getting it from your friend. I will ask Jehoshiba to present the first case.
Yes.
By then you arrange for it. Otherwise,
Yes.
what you can do is, you can ask one of your colleague in hostel, wherever it is, you please send your PPT to them.
Yes, sir.
Ask them to share from there. You can connect.
Okay,
Your
sir.
connectivity is good. You are able to join the Zoom, but the only problem is not able to share. So you
Okay.
check one of your co-PGs in the hostel and
Yes,
then
sir.
ask them to share the PPT and you join as a participant. That is the way out.
Okay, sir.
You have some time before the first case gets over, so you can do
Yes,
that.
sir.
Right?
Yes, sir.
Thank you very
Yes,
much. And
thank you, sir.
sorry for the delay, esteemed faculty. We have a very eminent faculty for the day. Professor Chintamani sir, one of the most revered teachers across the country, for kindly. Can you unshare for a moment, ma?
Yes, sir.
Very revered teacher amongst the students, and he's been kind enough in joining in spite of a very short notice. And sir is for people, I don't think anyone else will be unaware of him, but still, as a matter of respect, he heads the Department of Surgery at the Vardhaman Mahavir Medical College at New Delhi. And he heads the multiple societies. He is in the Code of Examiners, Advisory Board of the Royal College, American College. And then he did serve for a long time as an editor of the IJOS. And he is also on the review board of multiple journals. And his classes are most revered. And we have attended as postgraduates, and he continues to amaze us with the amount of updation and knowledge. So we have the other faculty, Professor Shantini ma'am. Shantini ma'am is professor and HOD from the government KP Vishwanathan Medical College at Tiruchirappalli. And we have our own senior faculty, Professor Sahai sir, Professor Jailal sir, Professor Srinivasan sir joining us. And we also could see Professor Narendra Gupta sir, and we could see Professor Mukesh Suvera sir and Professor Kiran. And I could see very eminent faculty joining us today. So friends, without much ado, we'll go for the first case. So the first case is a case of a cheek swelling, kindly permitted by Professor T. Srinivasan. Jehoshiba is going to present. And this is from Government Coimbatore Medical College. Jehoshiba, you can try sharing your PowerPoint now.
Okay, sir.
Please introduce yourself, your assistants, your unit chief, and then go ahead with the presentation.
Okay, sir. Sir, I'm not able to share my screen, sir.
You open the PowerPoint, it is there on the screen. Go back. Yes.
Sir, it is showing as you cannot start sharing while the other participant is sharing. Like,
No problem. You are already. Lavanya, can you please unshare now? You do it now, Dr.
okay.
Good luck.
Good evening to one and all present here. I'm 1 minute, sir. Sorry, sir. Sir, am I audible, sir?
You are perfectly audible.
Yes.
Good evening to one and all present here. I am Dr. Jehoshiba from Coimbatore Medical College. My HOD and guide, Dr. T. Srinivasan, sir. And today I'm going to present a case on preauricular swelling. US not. Chief complaints. My patient is a 70-year-old.
Your screen is not coming, ma. Only you are seeing you.
1 minute, sir. Sir, is it visible, sir?
Yes.
Kana, you go to the slide view, slideshow mode,
Okay, sir.
You please unshare this, doctor.
Okay, sir.
Close the PowerPoint on your desktop. Close all the windows in your desktop. Have done it?
Yes, sir. I'll try.
Okay. Now you press screen share. What are the options you are getting?
Document screen advanced.
Screen. Press the screen.
Screen, okay.
Yes. Now you open the PowerPoint. Yes. On the
No. Slideshow.
top, you can yes. Good luck.
Thank you, sir. Today I'm going to present a case on preauricular swelling. Chief complaints. My patient is a 70-year-old female resident of Coimbatore district who is a sanitation worker with a low socioeconomic status, presented to the general surgery OPD with chief complaints of swelling in the left cheek for the past 6 months. History of presenting illness. As stated by the patient, she was apparently asymptomatic until 6 months back when she noticed a swelling in her left cheek, which was initially about 1 cross 1 centimeter, insidious in onset, gradually increasing in size to attain the present size of approximately 3 cross 2 centimeter over the past 6 months. She had no history of pain associated with the swelling, no history of rapid increase in size of the swelling, no history of difficulty in swallowing, no history of drooling of saliva or difficulty in closing eyes, no history of swelling on the contralateral side, no history of other swellings in the head and neck region, no history of variation in size of the swelling while chewing food, no history of fever, no history of dry eyes or joint pain. Past history, she was a known case of systemic hypertension on regular medication. She had no history of diabetes mellitus, tuberculosis, bronchial asthma or mumps, no history of radiation exposure in the past, no history of major surgeries in the past. Menstrual history, she attained menopause at 48 years of age. Obstetric score was P2L2, full-term normal vaginal delivery. Personal history, she consumes a mixed diet, has a good appetite. Her sleep is undisturbed and her bowel and bladder habits were normal. No history of smoking or consumption of alcohol. She had no history of malignancy in the family. My summary, a 70-year-old female presented with complaints of painless swelling in the left cheek for the past 6 months, insidious in onset, gradually progressive in nature, with no history suggestive of facial nerve involvement or no history of previous surgeries. Sir?
Nice history. You made it quite exhaustive. There are certain terms which can be made a little. You better be sure it is left cheek, or you stick to it throughout. That's up to you. If it is in front of the preauricular region, we don't know what to say. And you started by saying, I'm talking about a preauricular swelling. So that's entirely acceptable. I don't really think that's a major issue. Coming to the next slide. When you talked about it, you were trying to explain it very nicely as to how did it grow and what happened to it. In your negative history, all that you mentioned was relating to the involvement of facial nerve or not. That is a perfect thing to do. And instead of running that laundry list of all the features which are very routine, you can actually, there are no clinical, as at a postgraduate level. I don't know, some people are fussy about it that you, although your conversation is in among surgeons, so you can be very straight. There are no clinical, there is no history suggestive of any facial nerve involvement, and leave it to the examiner to ask so that he can prescribe. Now, at the same time, variation style of doing is perfect, and the history of fever, dry eyes. I'm only looking at what you've written. I've not yet asked you anything relating to what can be asked, and it's a very important history. Pain associated with the swelling. What were you carrying in your mind when you took? Was there anything specific you wanted to know?
while asking pain associated with swelling, I was ruling out any inflammatory causes
So
or
ruling
any
out,
acute causes. Yes.
you answered it.
Yes,
Now,
sir.
difficulty in swallowing, what was it in your, what was it that you wanted to, you should know all the negative history. In fact, if you have to assess a candidate for performance, it's more about the negative history than the positive history. Because negative history is the questions that positive is what the patient is. So what is it in your mind that you want to know?
Difficulty in swallowing, I was ruling out whether patient had any history of trismus or any, in case of parotid, and any deep lobe involvement. In that case, patient might have difficulty in swallowing.
So trismus has nothing to do with swallowing. That patient will be obviously not be able to.
Opening them. Okay, sir.
That is different.
Okay, sir.
Rest appears to be all facial nerve related injuries. And one can easily see that you're trying to look at some kind of a Sjogren in dry eyes and joint pain. Now, don't have to be so direct unless the history is going to make any sense in your case. Next
Okay.
slide, if I may. Now, remember, I think it's a very common mistake, and I'm observing it all the time.
Okay, sir.
Diabetic is never a past history because once a diabetic, always a diabetic. Tuberculosis can be, neither is hypertension a past history. You can mention them as comorbidities, and that makes sense.
Okay,
Now,
sir.
what was in your mind when you were taking a history of radiation exposure in the past?
Sir, radiation exposure can be a predisposing factor in some malignancies, sir, associated with the parotid, like mucoepidermoid.
What
And
radiation you're aiming at? Oh, she says, I don't understand your question. So you have to be more precise with it. So what radiation exposure is relevant to you?
radiotherapy given to the head and neck, or radioiodine therapy for thyroid cancer.
Well, low dose radiations cause cancer or the high dose radiations?
High dose radiation, sir.
Well, it's just the opposite. The question itself is indicating the answer. It's usually the low dose. High dose is ablative. It would have destroyed the. If you have head and neck radiation, then most of these glands dry up completely. You know that Sika syndrome happens. Not that high dose cannot cause cancer. I'm not trying to say that, but it's commonly the low dose. And if you talk about radiation exposure in the past, so if it's only about radiotherapy, then maybe that may not be a very relevant history. You ruled out any cancer in the past, and then you're talking about radiation exposure in the past. So this will be not making any sense. Correct? So
Yes,
which
sir.
kind of radiation is low dose? So where all you can get,
Sir, pardon, sir.
where can you get the low dose radiations if you are unfortunate?
Low dose radiation other than radiotherapy, sir.
Obviously,
Uh,
radiotherapy, there's nothing like low dose radiotherapy, right? That's what I wanted to clarify to you. So
yes,
you
sir.
mentioned at one point no past history of cancer, and then you mentioned no history of radiation, past radiotherapy. Then that doesn't go along. It
Okay,
looks like run of the mill stuff.
okay, sir.
So low dose radiations usually happen if you're living close to some nuclear reactors, very much like the Chernobyl at the Hiroshima kind of things. So those
Okay.
are not common, or the patient is in that profession, radiation technician, etc. Right? What do you mean by no history of major surgeries in the past? What would be major and what would be minor?
Sir, major surgeries, if patient had any history of major surgeries in the recent past, patient can have uh, parotid swelling, which can be parotitis because of.
I'm not trying to put you down, but
Okay,
that doesn't make sense at all. So you have to be relevant in your history.
okay,
Just bring out a run-of-the-mill ABCD checklist kind of a history. So she has no surgeries in the past, no history of surgery. No minor and major is obvious. And major surgeries don't really have an impact on one side parotid growing. Even you know that. So don't try to create a story, right? It's not going to be acceptable easily. I have not gone through everything. I'm just touching few points. Next slide. Now, this was done well. And you in the menstrual history, you mentioned the obstetric score. I'm not trying to bother you with that. I am not fussy, but it cannot be in menstrual history. You also know.
Yes,
What
sir.
was in your mind when you were taking the menstrual history? Was there anything relevant?
Yes, sir.
So, doctor, why am I being so fussy? Why am I asking all these questions? I am a little finicky. But at the same time, these are usually cases where the examiner wants to be in a hurry.
Yes, sir.
To have a limited time, you should be able to speak all the important things rather than the whole laundry list. And in that laundry list, you're losing the focus because it's making no sense at all. All that I could make out from your entire history was there was a swelling in front of the ear, which you called cheek. It's all right. I don't think that's any problem. Rest, there is nothing positive in the entire history. I don't blame you for that because there is nothing positive in the history, so you can't blame it. But you could be more precise with that swelling and around that swelling, right? Personal history, routine personal history. Now, it's to your malignancy family. Which malignancy you're looking for?
Sir,
You speak out, ma. When professor is asking, you have to answer the question. That's mannerism.
yes, sir.
Hmm.
No, to rule out any secondaries, which to rule out whether it is an unknown primary with a lymph node in the cheek, sir.
Getting worked up unnecessarily. I'm on your side and I am your friend. That's why I'm trying to tell you many things. So don't be vague about it. Even when you're understanding. Forget about when you're presenting. The understanding is clear, your presentation would be clear. When you're taking family history in any patient, you should have a focus in your mind. You have to be relevant and focused. No history of any malignancy in the family. Now, the family could be 150 people.
Yes,
You cannot know about all of them. So you can be more relevant. There is nothing, no head and neck related malignancies or syndromic scenario in the close family relatives. You can't be talking about the whole family. I was judging by your answer whether you really paid attention to it. Just to say no malignancy in the family and then coming to unknown primary doesn't make sense. You first don't know that it may be a malignant swelling or it could be a benign swelling. You're right. But suppose it's a malignancy, then it's good to take that history. Right? Next slide. Next slide, please. Now that's your summary. 70-year-old female. Please make it into a lady, 70-year lady. Please, this is my request. If you give respect, you get respect in life. 70-year lady has presented painless swelling. Is it left cheek? I'm asking you for the last time.
it is a preauricular region, sir.
What would that be?
Sir, could be a preauricular lymphadenopathy, sir. It could
What
be,
would that
sir,
region be? No, don't worry. My question is silly. I'm not asking you about what is the differential.
sir,
What region do you think it is?
carotid region, sir.
Right. So you're scared of saying that, or you know it, but you don't want to say that because some examiners may say, "How do you talk about the region in the history?" So therefore, you can get away by saying in and around the year. If it is cheek, I'm okay with that. I mean, this is also acceptable. I'm not saying, but you stick to it and better be clear about it.
Okay, sir.
And you'll have to stick to it throughout because you've already seen the case. And you cannot say that when I was taking the history, I had not examined. And you cannot say when I presented, I did only one thing. You've already done everything. And now you're telling us the story. So I often tell my students wherever I teach that you don't try to bring out the salt, pepper, and everything separately now. The ingredients are all put in. You can prepare and you can pass on the right kind of a history. You don't have to repeat exactly what the patient said because that cannot be done because otherwise patient would be presenting that history. It's a clinician presenting a history to another clinician and both of them are intelligent enough to understand what is being spoken. Correct? You mentioned about trismus. What would that indicate here?
Sir, trismus involvement of the medial pterygoid muscles can cause trismus, sir. Or
Now,
a
in
normal
sorry. Yeah, please. Please get.
submucosal fibrosis.
No, be sure, is it the medial pterygoid is responsible for opening?
Sir,
What is the function of medial pterygoid?
medial pterygoid elevation, sir. Elevation of the mandible, sir.
So that will can only the close.
Yes, sir.
So you are talking about if the medial pterygoid is pressed, you will not get the trismus.
No, sir.
So the opening of the mouth is a lateral pterygoid.
Not.
So when lateral pterygoid is infiltrated, you will not be able to open the mouth.
In this connection, suppose it's a swelling that you're thinking it is. What is an easier way for this to produce trismus? You said submucous fibrosis. Will that be trismus?
Sir, that will not be trismus, sir. That will be painless, sir.
Be careful in answering, ma. Sir is very particularly he is putting the answer question to you.
She's answered it beautifully. Submucous fibrosis would be a painless restriction. Trismus is a painful restriction of mouth opening, but this can infiltrate into masseter also. That can also produce trismus, right? So you don't.
Okay.
There are some benign conditions which can produce trismus. It doesn't have to be malignancy. So what are the benign conditions that can produce trismus?
Benign conditions like parotitis, sir, parotid abscess,
Excellent.
Sialadenitis can produce, sir. When it is presenting with an parotitis or thing or
Right. You answered
Try
it.
to come out of parotid. Anything else?
Yeah. Well spoken. Come out of parotid now.
yes, sir. Mm.
Don't worry. Yeah, I'll tell you about a few which are very interesting and funny at the same time. One is the eruption of wisdom tooth, which doesn't happen to most wise people, unfortunately. So don't think wisdom tooth is to indicate wisdom in an individual. You know about that. Fracture, the temporomandibular joint dislocation. There's so many causes. So you don't have to associate it always with malignancy, while submucous fibrosis could be associated with malignancy. This is my little submission about your history. I enjoyed your talking, but importantly, what I observed, because you got a great mentor, so he's taught you well. What you're trying to do is you're using the same checklist in all cases. Be intelligent enough to say what is necessary, because otherwise you won't be getting time to speak what you wanted to say. By your answers, I understand you're a bright student, right? Did you talk about the discharge in the oral cavity? Probably not. Mouth opening, important for us, but they will come in the examination. So in the history, patient may not be able to tell you. Now, as far as I'm concerned, I'm okay with that. If I'm permitted, we can move on. Dr. Jailal, over to you.
Yeah, Jagosh, I mean,
Yes, sir.
what you are expecting from this patient and what is your suspicion by the end of the history?
By the end of the history, it can be a case of preauricular lymphadenopathy, sir. It can be a
So
lipoma.
you asked so many questions about the drooling of the saliva, closing of the eye, but for what reason?
So because it was in the region of the parotid, so I wanted to rule out whether the patient has any history of facial nerve paralysis.
It started as a one centimeter. Where you said it started as a 1 centimeter only.
Sir, yeah, it started in the preauricular region, sir. And
No, that is what we are doubtful. What is that preauricular region means?
it is, sir, it is in the parotid region, sir. Medial to the ramus of the mandible, sir.
Suppose the patient has to tell you this, and you run into a patient of that background, what will she generally tell you? Don't worry.
Is there any history of trauma?
Sir, there is no history of trauma, sir.
You have never mentioned that. Why not? It could be just fallen down, just a hematoma which is getting organized, getting into a calcification or something like that.
Yes, sir.
But because what we understand is you are only initially you are talking only about parotid, but suddenly you are coming down to the preauricular node. But you are not wide opening. You are thinking in depth other conditions of the vein.
Sir,
And
so because it was for 6 months duration and patient did not have any complaints of pain or
no, it was for you. You said 1 centimeter only, progressively increasing and attain the size.
yes, sir.
The same thing can happen with any trauma also.
Okay.
Why not? It is just a cutaneous lesion, sebaceous cyst or something like that.
So it can be a cutaneous lesion also, sir.
So something which, yeah, sir, please. Sir.
Yeah, please, Dr. Sorry.
No. What we could understand from the history is already you know some diagnosis. You want to fit into that, so you are asking some questions. Because because you are giving much importance to the facial nerve involvement, which is far away from the facial nerve. You are very much away from the facial nerve, and obviously you need not put so much of questions to that. And when you are thinking it is a preauricular node, and don't talk too much on the dry eye and dry, but you are not talking about the tongue or what is the dry mouth. So if you are talking on one condition, you should talk fully.
Okay.
Great points. And actually, anybody could judge that you got a frame and you're fitting a picture into it now. You should start with the picture, frame follows later. We can move to examination and then we'll get back to some more questions, I think. Yeah, let's start. Let's
Sure.
move.
On examination, after obtaining verbal consent from the patient, she was examined in a well-lit room in sitting posture, comfortable and cooperative, moderately built and nourished, no pallor, icterus, cyanosis, clubbing or pedal edema. Lymph node examination will follow. Performance status, Karnofsky 90, BMI 26. Vitals were normal, BP 130/70, pulse rate 89 per minute, regular rhythm, normal volume, respiratory rate 20 per minute, SpO2 98% in room air, temperature 98.8 degrees Celsius. On inspection, a single...
In the general examination, there are two things. Do the general examination. Okay. Why do you want to bring Karnofsky score here?
Sir, because it is a swelling, sir, and it can be a malignant swelling or it can be a benign, sir.
So why do you make 90? Why not 100?
Yes, because patient is able to perform all activities,
No,
sir.
no,
But
that is 100 also. That is same thing. No, why do you want to reduce it to 90?
So because patient has some symptoms of swelling, sir.
Right.
No, that is not.
Yes, sir. No,
Second, what is the BMI meter square?
Yeah. It's wrong, actually. No, when you're describing the BMI, it's a figure, right?
Yep.
It's not, and you don't need to mention height and weight if you're already giving the BMI. Okay. All you're trying to tell us is the nutritional status, performance status,
Yes, sir.
and that is a journal routine. And you said lymph node examination will be mentioned later. What do you mean by that?
Sir, regional lymph node examination I'll mention, sir. So
what about the generalized lymphadenopathy? This could be part of the entire. See, this all happens because you already got something in your mind.
okay, sir.
And if suppose this was even if you thought of it as a lymph node with some primary somewhere, the history of all those sites would be important, which did not show up, right? So be careful about it, right? So if you don't know the diagnosis, how are you going to approach it? That's how you should approach it, and be flexible in your approach.
Okay.
Moderate build narrage, no pallor, icterus, clubbing, colonical sinus is basically nutritionally preserved. Performance status is Karnofsky 90, what you mentioned, and BMI is 26, right? And
you have mentioned the position of the patient. You were sitting, and what was your position?
Sir, standing position, sir.
Standing and bending.
Yes.
So we normally recommend surgeon should never bend.
Yes.
you should sit at the same height and level,
Stand.
head and neck swellings, as he is rightly pointing out, and inspect from a slight distance before you get close. You may observe certain variations and certain abnormalities when you're a little away, and then come back to close. And how close is close? 60 centimeters, if you wanted to be very, very fussy about it.
Okay,
Don't get too close for comfort, you will see nothing. Because then you will see just a piece of rock. Like if you look at the mountains from a distance, then if you get too close, you won't see. Let's move on to, what did you mention? Next slide. These are the vitals. Next. Now, what inspection now? What are you doing here? You're doing regional examination. So you're doing head and neck examination. That's how you, or you're inspecting the patient as a whole.
No, sir.
So now you're describing head and neck examination. Am I right or wrong?
Yes, sir.
Okay. So head and neck examination. Let's start.
On inspection, a single swelling present in the left infrazygomatic region, approximately 3 × 2 cm in size, ovoid in shape, extending superiorly 2 cm from the zygomatic arch, posteriorly 3 cm from the tragus, inferiorly 3 cm from the angle of the mandible, with well-defined borders. Surface appears to be smooth. Skin over the swelling appears normal. Earlobe is not lifted up. Facial symmetry appears to be normal. No other swellings noted in the head or neck. On palpation, there was no local rise of temperature. No tenderness was noted over the swelling. Inspectory findings were confirmed on palpation. There was a swelling on the left infrazygomatic region of size 3 cross 2 centimeter, ovoid
Now,
in
see,
shape.
I'm sorry, I hate to stop anybody. You should finish with it. Now it is left maxillary region. Then at one time it became preauricular. At one point it became infrazygomatic. You decide on the region. I told you during history itself. Be careful with it. Where is this swelling located? What is this region called, madam?
Parotid region, sir.
Why, you either stick to that or you change your stance. You're frequently changing it. And what are the boundaries of parotid region? Okay, let me get down to basics now.
So boundaries of the parotid region are anteriorly bound by the ramus of the mandible. Posterior is the mastoid.
No, I'll have to stop you. I'm sorry, because for the benefit of others, we'll have to cut it short. It cannot be the anterior boundary, Parotid region is basically a square.
Yes, sir.
The upper part up, the zygomatic process, and then a line that goes across the angle of the mandible, correct? And two vertical lines. Midpoint of this zygomatic process vertically down, and from the mastoid process vertically down. That square is called the parotid region. And its significance is any swelling lying in that region is a parotid swelling unless proven otherwise. You may prove it to be otherwise, but that's how you define parotid region. Now, you can't be changing your position. If you're calling it infrazygomatic, the whole body is infrazygomatic. It is below that. That doesn't make sense. The regions are very specific. Please don't get it wrong. I'm trying to be on your side. I'm trying to make it easier for you.
Okay.
Is that okay? Now, you will decide now where do you call this swelling to be. I'm not suggesting it is parotid region, but I'm only wanting you to examine the patient. We're just looking at the pictures. So there is a single swelling in the left maxillary region now, but this is not maxilla.
It's not maxilla.
So
Sorry.
you have to be careful. In the left
And you are
parotid.
saying it's
Please finish now. We won't stop you, I promise. I just couldn't stop myself. Otherwise, you would go places. Now you can keep going.
Swelling in the left parotid region of size 3 cross 2 centimeter, ovoid in shape with nodular surface, well-defined borders, firm in consistency, mobile in both horizontal and vertical direction. Skin over the swelling is pinchable. Swelling is not fixed to the underlying masseter muscle. Swelling becomes more prominent on opening the mouth. There was no obliteration of the retromandibular groove. On bidigital palpation, on bidigital palpation, the stencil duct felt and normal. On bimanual palpation, the deep lobe was not palpable. No other salivary glands noted. Examination of the facial nerve, wrinkling of the forehead present. Closure of eyelids was normal. Prominent nasolabial folds. No deviation of angle of mouth. Taste in the anterior two-third of the tongue was intact. No bony tenderness noted over the angle of the mandible or mastoid process. Examination of the oral cavity. Mouth opening was adequate. Oral hygiene was fair. No halitosis. Uvula was central and no bulging of left tonsillar fossa. Movements of the jaw were normal. No cervical lymphadenopathy was noted. On systemic examination, the cardiovascular system was normal. The first and second heart sounds were heard. Respiratory system, bilateral air entry was present. Central nervous system, no focal neurological deficit noted. Per abdomen, it was soft, not distended, and no organomegaly was noted. Diagnosis: 70-year-old female presented with complaints of painless swelling in the left intrazygomatic region for past 6 months, insidious in onset, gradually progressive in nature, with no symptoms of local invasion, would probably be an accessory parotid tumor.
Okay, so this infrazygomatic, even parotid region is infrazygomatic, but you stick to that. That's your take. How did you check for taste in the anterior two-third of tongue?
Uh,
Did you honestly do it?
so patient did not have any complaints.
No, this is examination, doctor. You can be honest. We are talking amongst ourselves. Don't worry. It's not an exam.
Not done, sir.
If you don't do anything, that's why I wanted to drive home a point. Never say it. It's criminal to pull a lie in life in general, but in the exam, certainly. Don't tell a lie. It's a wrong thing to do. One, how did I catch it? Nobody does it. Why nobody does it? Because it's, how is it useless? It cannot be done properly. How many tastes you will check? So forget it. Right? And the entire 2/3 is the only tongue that you can feel because that's the oral tongue. Posterior 1/3 is pharyngeal tongue. So you only talk about tongue. Then uvula bulging you were talking about. Why should uvula bulge?
Any reason for that? We will have to bulge.
So how did it appear here?
Sir, uvula was central, sir, and tonsilla fossa were normal, sir.
That's
And
okay.
there was no bulge.
No, but you mentioned uvula central. I'm sorry about that. No bulging of the left tonsillar fossa. Movements of the jaw are normal. Mouth opening is adequate. And there was something else which got mixed up. You mentioned about, go back to the swelling, please. Yeah, we can stay here. No, we can stay there. That's okay. When you mentioned examination of facial nerve, you could simply get away by saying examination of facial nerve is normal. Let the examiner then ask you, what all do you look? Okay, that will help you. And then you won't be talking about this taste business and deviation, etc., which you already covered. You mentioned about
how will you palpate the deep lobe? Is it a bidigital?
Bidigital.
Palpation.
Here. How did he do that? Sorry, Dr. Jayala was asking. Yeah, I didn't hear that. Yeah.
Sir, can I interpret, sir? 1 minute, sir. Sir.
Yeah.
Jayalal, sir.
Please, sir. Yes.
Sir, this case came as presented as a swelling well in front of the parotid region.
Sir, that will come to the last.
We'll come to that. No, it's okay. It's okay. Actually, Dr. Srinivasan, this cannot fit into any other region, sadly. And parotid is not always confined to that preauricular space. It goes beyond. That's why they've defined a parotid region. It's going a little forward. It's a little more anterior. We'll discuss that. There's an important point there.
Okay. Please carry on, sir. Please. Sorry.
Yeah. How did you palpate for the deep lobe?
Yes, sir. By manual palpation, sir. It's not done, sir, because the gap.
I am requesting you, doctor, by digital palpation.
Yes, sir.
Deep lobe not palpable. That means you have done it.
Sir, by digital was done for the Stenson's duct, sir, and Stenson's duct was felt and normal, sir. By manual.
By digital for Stenson's duct.
What is the surface marking, or where do you palpate it?
Imaginary line is drawn from the tragus to the angle of the mouth, and mid 1/3, the Stenson's duct lie 1 centimeter below the.
Is it normally palpable?
It is palpable. It is palpable on taut masseter, sir.
Yeah, so you palpate it on a taut masseter. You don't need bidigital examination. Not for the duct. And it is not palpable, as you rightly said, unless it is either infiltrated or involved. Against a taut muscle, you are able to feel it like a cord. I am doing it just now. And you can roll it. Coming to the deep lobe not palpable, my request, doctor, is you cannot talk about something which you have not done. I'm requesting. Don't do in future. Deep lobe is not palpable. We don't attempt it unless there is a bulge there. Because if you do that, patient will have a gag. Unless it is enlarged and it come forward, you cannot do bidigital examination. And it's not called, it's not done as a routine. Please understand that. Stenson's duct is not, it can be felt, but it is not relevant in situations where it is not felt on a non-taut muscle, but on taut muscle it can.
Suppose you are seeing a bulge in that area. You are talking about no bulge. And what do you suspect? If there is a bulge, what are the possibilities you are thinking?
Sir, any bulge, it can be because of a deep lobe involvement. So deep lobe of the parotid
No,
can
that is one reason. Any other reasons? What are the conditions? You get a bulb there.
parapharyngeal mass, sir.
Potential mass. Suppose it is pulsating. How will you know whether it's internal jugular or internal carotid artery is involved?
Internal. Sir,
Okay, go ahead.
All right. So examination of you go backwards, keep going backwards. That's how we'll correct. Now, no, you all right. Let's start from here. Now, first you decide on the region. Now, you want to call it some region, then it cannot be just infrazygomatic. It cannot be supramandibular. These are not defined regions, so you got to be clear in that. A classical parotid swelling would be a little posterior, but it's a little, that's why you mentioned it to be an accessory parotid. Otherwise, why would you think of it as parotid at all? It's lying in the region, that's why you're thinking about it. You mentioned left ear lobule is not lifted up, correct?
yes, sir.
In what situation is it lifted up?
If it is a parotid swelling just below, if it is in the parotid space, it will be it will lift up the ear lobule, sir.
Only if it is filling the retromandibular space, no? Otherwise, it won't fill up. So if you're saying retromandibular space is not full, then how would it lift up? It can't lift up because it is to push the auditory apparatus up, so that won't happen. The other thing was you have described the extent. Superiorly 2 centimeter from posterior 3 centimeter. That's okay. You've described where it is lying. The picture shows it to be a large enough swelling to be going on all the sides. And let's move to the next one. Now, this I think is the repetition of the thing. Well-defined borders, permanent consistency. Does it become immobile on making the masseter taut? That is what our interest would be. Does it?
No, sir. It does not become immobile, sir.
Is it fixed to anything around?
No, sir. It is not fixed to any structures and any underlying structures, sir. Or it is not fixed to the skin also, sir.
No, skin I can understand. Now, what is what is a curtain sign in parotid?
Sir, curtain sign is because the investing layer of the deep fascia wraps the parotid gland, and the superficial layer will attach to the zygomatic arch. So any swelling in the parotid will not move in the vertical direction, sir, and
Very
only
good.
mobile in the horizontal.
So it is moving in both vertical and horizontal direction because it is a little anterior. That is how it's got more space there. Clear?
Yes, sir.
And it becomes important to understand this. Okay?
Yes,
And
sir.
next, I'll just skin over the swelling is pinchable. Don't keep repeating. Skin is not involved. That's what you're saying, right? Okay, you mentioned that. Let's go to the provisional diagnosis where you were earlier.
You said on opening the mouth, the swelling disappeared. Swelling size was reducing. And how do you explain that? When opening the mouth, somewhere you have put that on opening the mouth, the size of the swelling is decreasing.
On opening the mouth, the swelling became prominent, sir.
More prominent.
Because it was not, if it was a parotid swelling, it would normally become less prominent, sir. Now, because it probably it is not enclosed in the fascia, parotid fascia.
No, is it accessory parotid gland is within the fascia or outside the fascia?
Sir, it is outside the fascia, sir. It lies as an island separate from the main parotid gland, sir.
So it is in the superficial space.
Yes, sir.
If you had wanted to score more,
So,
you would have said the curtain sign is absent or present. Then you would have got a question. I don't know. You probably have got a little worked up and confused with the position, and you brought in a lot of stuff which may not be necessary, and you missed out on some important points which could have helped you. Right?
Yes.
Intraorally, you found nothing abnormal. That's what you have mentioned. And this cannot be a normal symmetry. So when you say facial symmetry is maintained, you got to qualify because there is a bulge on one side. How is it symmetrical? So can we move to the Dr. Jalal? Can we move to the
Yeah,
diagnosis?
yeah.
Yeah.
Yes, sir. Yes, sir. But you must understand accessory parotid is not on the superficial fascia. It is always look. In fact, sometimes it goes much more deeper.
Okay, sir.
So it is within that fascia, within the fascia, so not outside that. Okay.
I think
Go.
that's a brilliant question. Actually, it is the other way around. It will go downwards and deeper.
Down. Deeper.
You will find it. And a 70-year lady in a diagnosis, you don't start presenting complaints, etc. Now you need to come out with something definitive. A 70-year lady with a swelling in the left parotid region, which is likely to be benign and probably a parotid tumor, or you think it is malignant?
No, sir.
But you are not coming out with it. You are just still saying it is a parotid tumor. It can be benign, it can be malignant.
Yes. It is probably a benign parotid tumor, sir, because there is no history of pain, no no rapid increase in size of the swelling, sir, and no history.
Naturally, no, that's fine. Now, naturally, they will ask you three questions. Why is it parotid? Why is it benign? And what are the features that will indicate it is malignant? So this is how it's a takeaway question. In the exam, be right on basics. Describe what is necessary.
But Professor, is it clinically, can we make a diagnosis of accessory parotid tumor?
I would not. That's what I was coming to.
Okay.
And why should I even commit on that? Why should
commit on that? Wait.
I have no reason to. Please show us the picture. Please show us the picture, doctor. The picture of the patient. No, this lateral picture, lateral. Yes. Please draw with your cursor the parotid region now.
Okay.
Where is the zygomatic process?
Yes, sir.
Take the line across midpoint, down now.
Yes,
Vertically. I think you can be better than that. Yes. And mastoid? Mastoid is further up, vertically down. No, that's not vertically down. And then take the angle of the mandible, draw a straight line. So it is lying in the parotid region, and you can then keep beating around the bush and survive. Rather than committing on accessory parotid tumor, you think it's a parotid swelling, but I have a differential. Then you can talk about other possibilities. It will be a defensive approach. And as Dr. Srinivasan was trying to say, it may not be a classic. We have seen many parotid slide a little away. It's not always the case. And they may not be accessory because in that zone they can develop. That's why they've given this definition of a parotid region. So you don't have to say accessory and don't have to get so focused on in your clinical presentation. I'm only looking at it from the history examination point of view. Provided and I don't believe I know the diagnosis. Examination of the ear would have helped you. That would have been positive. And then examination of the scalp, because no examination of head and neck is complete without examination of the scalp, ear, nose, and throat, because it could be a lymph node, which could be the primary, could be anywhere. So that is why it becomes a very good case to discuss in the exam, and nobody fails in this case unless one is seriously looking for trouble. And this is one of those things, like accessory parotid tumor.
Making a commitment as a only diagnosis with accessory parotid tumor will always not go good. No? That will always tell that you have already know the diagnosis and coming out. You would have had a differential diagnosis, thinking parotid, discussed many things.
Perfect point. Jeho, Shilpa, you could then discuss later on. Examiner may ask you, do you think it is classically placed for a parotid swelling? You could say, sir, not classically, but I can't think of anything else. It is lying in the parotid region, and I would think about it as parotid. Let me be proven wrong later on. Now, I don't know what it came out to be. I'll approach it only on these lines. Do you have a differential?
Sir, it can be a preauricular lymphadenopathy, sir, because it is mobile in all directions.
Why is it not?
Sir, it is because it is mobile, sir. It can be because it is mobile, sir. And
When answering these questions, Joe, always say points in history and points on examination.
yes, sir.
Need to have, therefore, a good history covering up for all the primary sites from where the lymphatics can come, which you should have covered in your history rather than the rest of the stuff. 2, an examination, where do they lie? They don't go like parotid anywhere. Lymph nodes tend to be very loyal to where they are. So this would be filling up your preauricular space. The swelling has moved on. Be careful about it. They just don't go through the laundry list. That's what I told you. Checklists are dangerous when you're talking about a clinical case presentation. It can be anything. And at the end of the day, clinical examination is always qualified by investigation. So history-wise, examination-wise, you need to be talking.
Okay.
And then, is it possible for suppose it's one node, can it grow to that size?
Sir, with no no swellings in the head or neck, sir, or any associated factors, sir. It can. I think that it can.
Why do they make all lymph nodes that are more than 6 centimeters as N3? Is not because the node is big enough. It is supposed to be conglomeration of various nodes, because a single node cannot grow to that size. It will rupture, right? So some logical basic approaches. Now, how do you proceed with, because we have time limit, I can't go on and on. We can discuss more things. But suppose you have made a differential and you stick to that. Naturally, the moment you say accessory parotid, they will be suspecting your intentions. It is safer to call it a swelling in the parotid region, which could be benign or malignant. There are no points in history to suggest malignancy. There are no points on examination to suggest malignancy, and you're not duty bound to call it malignancy. So it's fair that what you're saying. But it's lying in parotid region and you are unnecessarily getting worked up on that. It could have been a simple, straightforward pleomorphic adenoma of the parotid also. We don't know. So discuss it generally as a parotid swelling with various differentials in your mind. That's it. It could be a lymph node also. Now, it can be any God-forsaken thing. That's a different story. Common things are common, rare things are rare. Don't talk about rare things when you can get away by speaking about common things.
Common things.
The exam is not about your diagnosis. Nobody cares for that. We all know if you know all the your investigations are there, you'll pick it up. How do you proceed quickly in 5 minutes? Can you wind up your case in 3 minutes?
Yes, sir. I'll proceed with ultrasonography, sir. To confirm the organ of origin, sir, and to look for the echo texture and the lymph node status, sir.
You're letting down your mentor. Dr. Srinivasan is too good a teacher. You'll be missing it. Please take
Sir,
care.
good evening, sir. Sorry to interrupt, sir. Good evening, sir.
Evening.
Sir, I have a doubt to Professor Sindhamani, sir. Can it be a minor salivary gland tumor, sir,
Absolutely.
as
It
a differential diagnosis?
can be a very important differential diagnosis. In fact, it must be one of those. And they are very commonly seen in this region. And minor salivary gland tumor is a differential. I was coming there. Thank you very much for reminding us. But I was more struck with the process that she was approaching it with. Like told you about points in history and points in examination. Also in investigation. Investigations to confirm the diagnosis, to support the diagnosis, to stage the disease if it is cancer, and to treat the patient. That takes care of a broader answer in the exam and you get your 50% straight away. Rather than talking about ultrasound, which is right, I'll also be doing that. So ultrasound is an extension of clinical examination, so you'll do that first. In most other swellings, we usually do triple assessment, like in thyroid and like in very swellings around breast, etc. So be careful in answering. Answering is also about how do you answer in the exam. You score over that. Now, how do you approach it? Ultrasound, what are the features you're looking at?
I'm looking for the echo texture, sir.
First of all, you would like to look for organ of origin.
Of origin, sir.
Why do you say it is accessory? Why is it not arising from the minor salivary gland?
Sir, it can be a minor salivary gland, sir, but mostly the minor salivary glands are located in the buccal mucosa, sir.
Buccal mucosa is not just mucosa, no? It can go outward.
Yes.
And that is where your swelling is lying. Minor salivary glands are a differential in most of these cases. So you can't be wrong if you say that. You're understanding? How many minor salivary glands are there in the oral cavity? I won't ask you, but if you answer, whenever we meet, I'll take you for a coffee. So answer that question.
Sir,
I pay for it. If you
major
don't
salivary,
answer, you pay for it.
major salivary glands are three
I
pairs.
asked you mine.
The question is only minor. How many minor salivary glands?
So more than 800, sir.
Oh, you're right. So you can have your coffee at home. Enjoy yourself. Now,
Srinivasan sir will give the coffee.
and that coffee is on you.
Sure, sir.
Yeah,
At Agra, Chintamani sir will give. We can get.
we'll have it. Now, importantly, doctor, you are a bright student. It's just that you got stereotyped into saying things that most people teach you into saying. It is not about saying what exactly is taught for one case. Every case is different. Have that flexibility and have an open-minded approach. So you'll do ultrasound, find out the nature, the origin, etc. What did you say about the nature? What would you see? Ecotexture.
Texture.
What would define a malignancy?
Area, sir.
What would define a malignancy on ultrasound?
Sorry. Variable, sir. Solid and cystic areas, sir.
What do you call that? Heteroechoic.
Heteroechoic, sir.
There are terms for everything. I won't take theory exam class here. You should read more, friend. And then you go for investigations to do further things. What does your picture show? Something is visible?
Yes, sir. This is the normal parotid, sir. And this is the swelling located above the masseter, sir.
So how does it become an accessory parotid for you? They look so different from each other.
Yes, sir. Sir, because it is a tumor, sir.
You can't be failed for this because this is not a part of your clinical presentation examination. I'll hand you over to Dr. Jailal for any more questions. Then I'll get back to you. Will do even here.
You have put us in ultrasound guided FNAC. Why do you want to have ultrasound guided FNAC?
Sir, USG guided FNAC, sir, because to to avoid nerve injury, sir.
There you are. He was using the correct terminology and you modified by saying USG guided. That was a mistake. Listen to the examiner. He said ultrasound guided FNAC, which is the correct terminology. Correct? And secondly,
ultrasound picture?
No, it is not.
Is it a ultrasound picture?
No, it's a CT.
The CT. I was asking what is visible in the CT. Now, she was talking about ultrasound. When you're doing ultrasound guided FNA, wherever you're doing it, it is to find the most representative area so that you can get the right yield. You don't hit into dead tissue. That is what he was trying to ask you. Please understand the question that the examiner is trying to ask you. And then you will proceed with CT, etc. I think we can stop there unless Dr. Jailal, you want to discuss.
No, please, sir, go ahead, sir, go ahead.
We can actually, since we have a second case also, that's what Dr. Kanagavel was saying. So unless he wants, if there is only one case, we can go ahead. Is there something more you want to talk about? How would you proceed further? If FNA is showing it to be pleomorphic adenoma, how do you manage? I think you go back to the previous slide, please. Don't show us this CT. Yeah. So accessory or not accessory. Suppose it's an accessory parotid and there's a parotid already existing. There's a gland also visible.
Yes, sir.
Accessory, what you say? What do you do?
Sir, sorry to interrupt. How can you diagnose an accessory parotid from the ultrasound, sir? It's my doubt.
At all, I don't use this term in the first place.
Sir?
I will be calling it a parotid swelling unless I've proven it by investigations, and then I'll get its nature on ultrasound. How would you call it accessory is not related to ultrasound features. Accessory is the side.
Nothing to do.
Yeah, it is not something. Accessory means like you have the accessory breast. It will be located in the region, but not exactly where it is supposed to be. There are sometimes swellings in the tail. Sometimes the swellings are just along the duct, the swellings may appear, like she mentioned also. So it may not be a classically located parotid tumor. but that doesn't make it accessory as far as I understand, unless somebody else has to say something.
Yes, but did you keep a possibility of skin adnexal tumor here? Did you keep that possibility or not?
No.
Sir,
No, I think that's a very important differential diagnosis in this patient. The patient is having the skin adnexal tumor is there.
Will the skin be free or involved in that? That's a question.
skin will not be free, sir, in that case.
Sometimes
What is
it
happening
will be
here?
also, and you may have, these are rare tumors and they're mostly malignant. The minor salivary glands, similar, I'm just taking a leaf out, they tend to be more malignant than the major one. So you have so many options, but when you're saying something arising from skin, the skin would be generally first involved, and its skin is not free, then we suspect it to be something deeper than that. And did you feel the groove in between the parotid region and this? Was there any gap that you could appreciate? I think we are going too far into it. She is
What is the blood supply to the accessory parotid tumor gland? Is it from the same or different?
It is from transverse cervical artery, sir.
Can transverse cervical artery reach there?
Sir?
Now you opened the Pandora box. No, where does transverse cervical artery arise from?
Is it in the neck or in the face?
Let her answer. Where does it lie?
Sir?
Where does transverse cervical artery lie?
It lies in the neck, sir. Sorry, sir. Maxillary artery.
So
If
you are right in saying the transverse, but it is a transverse facial artery, not the transverse cervical artery.
Exactly. Yes, yes. So don't Google around because the most dangerous source of information is Google. When you start Googling around, read it, come prepared. Don't make you, if you could, I mean, if I were you, you should take home some answer. No, otherwise we are just asking you and bothering you. I would call it 70-year lady with a swelling in the parotid region, likely to be a benign tumor of the parotid, with no features of infiltration or involvement of any adjoining structures, including facial nerve. I'll throw it back to the examiner now. Then he'll ask me, do you think it is classically lying in the parotid region? Not classically lying, sir, but it is kind of interjecting. So what are the boundaries of parotid region? Answer that. Now, what else can lie here? Answer that. How would you proceed? Answer that. How would you manage? Mention what you know and come out of the exam and pass your exam. Nobody will treat it based on our history and examination. We'll have to investigate. And that will change many things. Correct? But you should be logical, commonsensical in your approach. Don't create a problem by picking up rare things which confuse you as well as the examiner. He is also trying to ask you some basic questions because he wants to find out what you know rather than what you don't know. But that is very easy to find. Okay? Like somebody mentioned, minor salivary gland tumors are common in head and neck. You can use that. And all questions around it were asked. Basically, the examination was done with the history and examination only. And 4 to 5% is about what will you do, what can happen, what are the possibilities. And a very important point was brought out. We have seen adnexal tumors in this region, but then you will see for the regional lymph nodes, which you will mention, adnexal tumors are not always malignant also. So there is a point there. But generally, adnexa means, it has to be involved by that. So you look at it from that. I think that's true. Dr. Jailal, unless we finish
you can tell what was the pre-operative histopathological diagnosis. Just show the operative slides, please.
So what was the Dr. Srinivasan, you can tell us?
No, he has got the operative pictures, sir. What was the pre-operative diagnosis? And what was the final histopathological examination?
Sir, the final
Where are the pre-op post-op pictures? The intraoperative pictures. Where are they?
Maybe she doesn't have it. It's okay.
The post-operative histopathological examination came as the pleomorphic adenoma, sir.
There you are. That's what I'm telling you. So
that is a better answer, sir. Always say that parotid, then it will be safe. Don't come into the accessory parotid.
No,
That's what
Jailer sir, the
Well,
intraoperative pictures showed that the gland, the tumor was well away from the parotid.
it's possible. It's possible.
Possible, sir.
The parotid was normal. That's what I asked her to put down the pictures. PG
Very nice.
Listen to us.
Very good case and very well managed, Dr. Srinivasan. The student
Not like our retrosternal thyroid, where the blood supply is same, continuity is maintained. Parotid, always it is a separate blood supply. Even the duct sometimes comes separately and opens into the tension duct separately. So it can be a wide apart from that, but much not in the superficial fascia. It is in the deep fascia only. It will be there.
Here the gland was totally normal, sir. This was something away from the gland.
So what was the surgery you had? What was the surgery you had done?
So we did as a parotid. This
that's fine, sir. That is what the surgery is also parotidectomy.
Open, looked at the gland. No, we didn't do a superficial because the gland was totally normal. No, that's what I want to ask. Did I make a mistake in not doing?
No, sir. Absolutely no. Absolutely no, sir.
Because the gland was normal.
Yeah, and actually, I was going to ask her the FNAC, the limitation. The minimum biopsy in parotid swellings is superficial parotidectomy, and it may not be done in all cases where the swelling is lying away from it. But we have seen it happen many times. It's lower down also many a time. We have found it is beyond the tail also, and has nothing to do with facial nerve. And these patients don't have any issues with the facial nerve naturally because you're not dealing with it. Excellent presentation. Thank you very much. We're getting a message.
Thank you for guiding us, sir. Thank you.
Thank you, sir.
Well done. You've done very well. Don't worry about it. But you also learned not to pull a fast one. Don't to talk what you did not do. Yes. If you did not do a very good answer, I did not do it. And don't do what is not required. There are do's and don'ts in exam. Don't work and in life. Don't ever say wrong things. Surgery is about honesty. If you have not done it, say I have not done it. Okay, that's very, very important. That's
omission is better than commission. That is, commission is something that as you have done, that is always better. You can omit that. Nobody is going to find fault with it.
That omission is better than commission. That is a surgical pearl that you can carry home. It's important. Don't say I tasted, because you know nobody does it. I tasted for the salt in a tier 2/3 and all that rubbish doesn't work. And it's not needed. Nobody's impressed by that. Okay. Thank you. Well done. God bless you.
Thank you, sir.
Can I press the PowerPoint, ma? Open that file. Make it in full screen. We are unable to see you, ma. Please switch on your video.
Good evening, sir.
We are still not able to see you, Kana. What is the device you are using, ma? Doesn't look like a laptop.
Good evening, sir.
Now, okay, you start your presentation and finish. Kana. You find difficult to follow all the norms. We are unable to see you, but start your presentation.
Yes. Good evening, all. Myself, Dr. Lavanya from Tirunelveli Medical College. I'm here to present a case of secondary snake. Mrs. X, 69-year-old lady coming from Tenkasi, who is a homemaker, came with chief complaints of swelling in the left side of neck since 2 months, cough for the past 2 months. History of presenting illness. Patient was apparently normal before 2 months, after which she developed history of swelling in the left side of neck for the past 2 months, which was initially small in size, rapidly progressed to attain the present size, associated with pain for the past 1 month, which is vague, dull aching type of pain relieved by medication. History of cough since 2 months. It was a dry cough, not associated with hemoptysis. History of loss of weight and loss of appetite was present. No history of fever or evening rise in temperature. No history of any other swelling. No history of skin changes. No history of discharge from the swelling. No history of excessive salivation or halitosis. No history suggestive of Horner syndrome. No history of loss of movement. No history of pain around the eyes. No history of ear pain, hard of hearing. No history of epistaxis. No history of change in voice or hoarseness of voice. No history of difficulty in breathing. No history of odinophagia. No history of melena. No history of jaundice. No history of bone pain. Past history initially evaluated at Tenkasi GH for the present complaint and then referred to Tirunelveli Medical College for further management. She's not a known case of tuberculosis or thyroid disorder, no history of previous irradiation or surgery, no history of drug intake, no history of drug allergy. Personal history, takes mixed diet, sleep pattern is normal. She's not a smoker, alcoholic, tobacco chewer, attained menopause at 42 years. Family history, no significant family history. Summary, 69-year-old lady with rapidly progressive swelling in the left lateral aspect of neck with history of cough and loss of weight for the past 2 months.
Excellent history, very crisp, to the point, and focused. What do you mean by significant family history?
Since the swelling is present in the neck, it may be a metastatic deposit. So in family, if CA breast is present or any GI malignancy is present.
Madam, don't say significant. Just get away by that. You should describe it in brief way. Now, what were you specifically looking for? Because most people get away by saying nothing relevant, nothing significant, not the same problem. So you can be more precise. This would have become even better. Your history was by and large otherwise complete. I had no question to ask you, but this you left open-ended, so I asked you. Can you be precise with it?
Family history, sir.
What would you specifically ask? The family.
Any CA stomach, sir, carcinoma stomach.
A general rule which I'll suggest to you, which will help you in all exams. There is no family history of any syndromic disorder.
Okay,
no many cancers in the family, head and neck specifically, or any other genetically inclined or genetically related cancers in the family. So you can be a little more precise with it, rather than no significant family history, because family history is always significant. There'll be something in the family, but pertaining to your case, correct? And otherwise, you've covered up the aerodigestive tract, upper one, lower one, and then you covered up for breast. You covered up for most things. I don't have anything to ask. If somebody else has to ask,
yes.
Can we move?
Yeah, Dr. Lavanya. Dr. Lavanya, good evening. Dr. Sai here.
Good evening, sir.
Right. So, boy, you've got just a swelling with no other symptoms.
It's a history of cough, history of loss of appetite was present, sir. Loss of weight is present, sir.
So, what was the cough like? I mean, have you described what the cough was all about?
It's not a productive cough, sir. It's a dry cough. It's not associated with hemoptysis.
How will this cough be significant?
Maybe
if you're going to relate it to the lymph node, if you're going to relate it to the swelling in the neck, how would this cough be significant?
Since the patient is having swelling in the neck, it may be of tuberculous origin or maybe a metastatic deposit from lungs, sir.
So what kind of cough are you looking for?
Clearly understood, like Dr. Rajiv is trying to ask you, how would the cough be connecting to what you're trying to do?
Since the patient is having dry cough, it may be a metastatic deposit from lungs, sir.
Look, Dr. Lavanya. The seasonal cough is different from a cough which is because of any malignancy. How is it different?
Seasonal cough
is
will
it
be
a seasonal cough?
medication.
Is it a seasonal cough, or is it something to do with your case? Now that you mentioned that he's got cough, which is persistent, I believe.
Yes.
Is it persistent?
Yes, sir.
Yeah. So how will you how do you differentiate a seasonal cough from a malignant etiology cough?
Seasonal cough on the season, since the cough will be relieved, or by medication it will be relieved, sir.
So it goes away.
Yes, sir.
Right?
So I think with that we can extrapolate it for others also. I very rightly brought out anything like hoarseness of voice, cough, as he mentioned, it has to get worse with time. So persistent cough is what he's trying to ask you specifically.
Yes.
Not just cough. Correct?
Yes.
Similarly, if somebody's got hoarseness of voice, hoarseness can happen due to sore throat. But is it getting better after some time, or it's persistently getting worse? That is what bring out the the relevance of it being malignant. Correct? Horner syndrome, what did you have in mind? You brought out directly. It's like a open blast thing. So what relevance do you attach to Horner syndrome? You mentioned
I mean,
horn.
why do you mention Horner's? Why do you mention Horner's?
Horner's, since swelling is present over the lateral aspect of neck, it may infiltrate the underlying structure, sir. Once the cervical sympathetic chain is involved, there will maybe Horner's syndrome, sir.
So it may involve nothing else but the cervical, the sympathetic chain before it involves. See, I think that I mentioned in the previous presenter's case also.
Yes,
When you're presenting a case, you've already done the examination and you've taken
yes,
the. So few things in the history you can omit and be more precise with because you've already done that part. I don't know how to drill that into students' mind. I always find that quite different. I mean, they have taken a history, now they've frozen that. Then they go to examination. The two are connected. You may actually, where is it located? In which, at what level?
level 5, sir. Over the posterior triangle of neck, the node is present.
Where is the sympathetic chain?
Sympathetic chain, the carotid triangle. Behind the carotid.
Is the carotid triangle a part of posterior triangle?
No, sir.
So you're trying to make it relevant. I have no problem with that. But it cannot be singularly going and involving the sympathetic chain without having involved the brachial plexus or the phrenic nerve, and it crosses all the way to involvement. So be at least these leading questions make us suspect that you're just checking the list, like in the previous case we were discussing. So you present it so well, so you could. I mean, I am not impressed with Horner's syndrome, but if you want to mention it, you better have a reason. It is possible still, because there may be something that is, in addition to this node, there is some other node. Or there is a primary which may be, is there any primary disease which can produce Horner's here, which may be related to this lymph node?
Thyroid malignancy, sir.
So we could be linking it to something. Otherwise, it may not make sense. Okay? And thyroid malignancy, especially if they're going in the retrosternal way. So it doesn't happen all the time. Okay? And one more thing you asked was odynophagia. So when you're saying odynophagia, what was in your mind?
If primary may be in the hypopharynx or
So the present with odynophagia or with dysphagia?
Dysphagia, sir. Or in the cervical esophagus.
So when will you get odynophagia? Sorry, sir, please.
If you said dysphagia, would that include odynophagia?
No, sir. Painful swallowing is good enough.
I'm asking something. If I say dysphagia, wouldn't that include odynophagia also?
No, sir. Difficulty in taking food is dysphagia.
Dysphagia with pain. No.
Yes, sir.
But it's a type of dysphagia only, no?
Yes,
Patient has no dysphagia but can have odynophagia. Is it possible?
No,
so it is therefore not making
sense.
No history of dysphagia and no history of odynophagia. So it would be one, that is dysphagia, as Dr. Sai was trying to ask you. It's commonly dysphagia. Odynophagia happens in hypopharynx, you're right. But then you are trying to, again, be very, very, very copybook. You have a thing in mind and you're putting, the square painting in a round hole. So that around this thing frame. Otherwise, I don't want to spoil your history. It's well spoken and you covered all the points, but I hope you know about them. We took history of aerodigestive entire tract, history of lower GI you took. Anything significant, you said nothing. So out of nowhere, there is a node, which is what Dr. Sai was asking you. So the only complaint is the node.
Yes.
That's all the patient noticed.
Yes, sir.
Okay.
Okay. So in your history,
yeah, please.
Sorry.
Please.
In your history, where do you think this is the source of the primary for these nodes? Where could be the possibility of the primaries? One you said aerodigestive.
Yes, sir.
One you ruled out thyroid, breast, and GI. Any
Yes,
other
sir.
important thing which you can relate to?
Ruled out oral cavity also, sir. Submandibular and parotid glands.
Aerodigestive you done. Fine, I agree with you.
Parotid and submandibular glands, sir.
Okay. What about malignant melanoma?
Yes, sir. Malignant melanoma.
Right. So you should ask for any skin lesions
Yes, sir.
in the upper chest and the right, because they are known to produce this kind of thing.
Yes,
Okay. So please.
Now, let's go to examination. We'll again come back to history. There'll be many questions that get briefed. Dr. Jailal,
Yes.
can you go on?
Yes, sir. Please go ahead, sir.
Yes, please go ahead. Examine.
General examination. On examination, patient is moderately built and nourished, conscious oriented. ECOG is 1, BMI is 19. There is no pallor, icterus, clubbing, or pedal edema. Vitals, BP 110/70 mm mercury. Pulse rate is 86 per minute and respiratory rate is 16 per minute. This is a picture of the patient with neck extension and lateral aspect of neck is shown. This is with sternocleidomastoid muscle with resistance is taken. Examination of neck. After getting informed consent, patient was examined with adequate privacy and light exposure. There is a single discrete ovoid swelling in the left lateral aspect of neck over the posterior triangle of neck of approximately 5 × 4 cm, posterior to sternocleidomastoid and anterior to trapezius muscle with smooth surface and well-defined margin. Skin over the swelling is normal. There is no redness, scar, sinus, ulceration, or discharge, or there is no dilated veins. There is no visible pulsation. On palpation, inspective findings are confirmed. There is no warmth, no tenderness, a swelling of 5 × 4 cm in the left lateral aspect of neck over the posterior triangle, extending 4 cm below the angle of mandible and 4 cm from middle 1/3 of clavicle for about 5 cm vertically, 5 cm from the midline and 3 cm anterior to trapezius for about 4 cm horizontally. It is ovoid in shape. The plane of the swelling is deep to deep cervical fascia. It's a nodular surface, well-defined margin, hard in consistency, mobile in horizontal and vertical direction. Skin over the swelling is pinchable. There is no fixity to underlying structures. Bilateral carotid artery is palpable. Examination of contralateral neck, clinically no palpable swelling. Examination of other system. Thyroid, no nodules felt. Breast, no lump palpable. Examination of oral cavity, tongue, hard palate, soft palate, gingivobuccal sulcus, posterior 1/3 of tongue, retromolar trigone. There is dental staining, no ulcer, no leukoplakia, erythroplakia, submucosal fibrosis. There is no trismus. Examination of parotid and submandibular gland is normal. Examination of ear and nose is normal. Examination of axilla inguinal region, no nodes palpable. CVS S1, S2 plus. Respiratory system, bilateral ARN3 present. Per abdomen, soft, no organomegaly, bowel sounds present. On digital rectal examination, tone is normal, normal fecal staining. There is no evidence of deposits and no bleeding. On pervaginal examination, uterus is anteverted, os is posterior, fornix is free. 69 female with rapidly progressive swelling in the left lateral aspect of neck with history of cough and loss of weight since 2 months. Clinically, hard nodular swelling is present. Provisional diagnosis, a case of secondary SNEC involving the left level 5 node. Nodal staging is N2A, maybe query lung carcinoma or query unknown primary, sir.
Very nice. Can you show the picture, please?
Yes.
One, you showed it very in a hurry, so we could not see it. Yeah. Where is it located?
Posterior to sternocleidomastoid and anterior to trapezius, sir, in the posterior triangle of neck, sir.
Now, what all examinations would be mandatory to mention here?
Examination, sir.
Where is the Erb's point? Take your cursor there, please.
Yes.
You can't see the pointer, so you can take the cursor if you can, please. Or you can, yes. So that's a Erb's point. How do you define it?
Posterior to the sternocleidomastoid.
No, what is the Erb's point?
It's a point that's formed by the brachial plexus.
No, brachial plexus is lower down, madam.
Yes, sir.
Is where the
Erb's point cervical plexus forms.
Yes. So greater auricular nerve winds around the sternum. And also the external jugular cross is there. You can see that. What is the significance in this case? 2 centimeters superior to this point is where the spinal accessory would emerge. So examining spinal accessory becomes important. The Erb's point you are talking about is the Erb's paralysis point in brachial plexus of the upper trunk. We are not talking about in connection with neck dissection or neck nodes, right? So you say it's a lymph node?
Yes, sir. Mobility is present in horizontal and vertical direction, sir. If the nerve is involved along the course of the nerve, the mobility will be restricted, sir.
No. You don't test mobility against a nerve that way. If the nerve is involved, patient will have involvement of which muscle. Shoulder movement would shrugging would be affected.
Trapezius will be involved.
So this examination is not there. That's why I was asking you.
Yes, sir.
movements at the shoulder joint were necessary for involvement of the brachial plexus. And examination of spine accessory was necessary for the the movement of the shrugging of the shoulder was essential. Although I can see the trapezius is standing out, so it is not in. My question is, why do you say it is a lymph node?
It's present in the posterior triangle of neck.
I'm not falling into your script now. Your script is you have prepared unknown primary, and that's not what we are going to ask you. Common sense. That's how examination goes. Now, there is a swelling in the neck, which is the only swelling in the neck.
Yes, sir.
It is lymph node. Is it one lymph node?
Yes, sir. Single node, sir, with nodular surface.
Even if
it's
you
not
look
do you expect a single node to have a multiple nodules develop in the single node?
Naturally, even your picture is showing it's a more than 2 or 3 nodes together. And you have no feature in your history and examination to think of anything which is malignant. Why do you say it's a malignant lymph node in the first place?
Elderly, sir. 69 years.
Old, she must get malignancy. Not fair. Age is a feature, all right. How old is she?
69, sir.
You're making us all fossils. 69 is not old now. Not that we are 69, but don't 69-year lady must get malignancy. That's not true.
Yes.
Anything else? She's 69, so she's got malignancy. Any other thing? I don't think it is malignancy. Then I mean, I would not bother about all the examinations you did. You actually got the hell out of the patient. Every possible organ was examined, which is a good thing you did. But simply assuming it is malignancy. What are the characteristics of a lymph node that will make it a malignancy? You're not telling me that. You just
hard
told me.
in consistency, sir.
Hard. Is it hard in consistency?
Yes, sir. Hard in consistency, sir.
But you have done the fluctuation test also, no?
Yes.
No, sir.
You have mentioned this fluctuation is negative. So when you are first thing you are making and swelling is hard, will you go and do a fluctuation test?
So no, sir. Fluctuation I have not mentioned, sir.
You did not mention, okay. You said it is deep to deep fascia. How do you establish that?
On extending the neck, the swelling becomes less prominent, sir.
So it is deep to deep fascia. Is that the easier option? Please show the picture. Don't run away from the picture. That's the key. Now, what is its relationship to the sternomastoid? You mentioned something, but we couldn't make out.
It's posterior to sternocleidomastoid, sir.
No. Is it superficial to that plane or deeper to it?
Superficial, sir.
Oh, so how would it be superficial to sternomastoid? What is investing layer of deep fascia? What does it invest?
Invest trapezius and sternocleidomastoid, sir.
So is it deep to deep fascia or superficial to deep fascia, this swelling?
Deep to deep cervical fascia, sir.
So then how would it be superficial to sternomastoid? Which lymph node groups are superficial to sternomastoid, madam?
External jugular nodes present over the external jugular vein, sir.
See. Now there are 2 groups of lymph nodes in the neck. Superficial groups.
Superficial and deep, sir.
Cervical. Right?
Yes, sir.
Now, superficial groups are preauricular, buccal.
Preauricular, postauricular, submental, submandibular, and occipital nodes.
No. Submental is deep. That is level 1A. 1B, submandibular. 2, 3, 4 are upper deep cervical, middle deep cervical, lower deep cervical, and posterior
Nodes
level.
present over the external jugular and occipital nodes, sir.
This is a superficial group of lymph nodes according to you?
Deep cervical nodes.
All right, I won't drag much. So the basic blunder, so I would not take you there. It has to be, if it is deep to deep fascia, it cannot be superficial to sternomastoid. So that is nonsense. You should be careful about it. Now, so is there any finding to make it a metastatic lymph node firstly? Why is it not a primary lymph node disorder. You think it is malignant. That's what you told me. Why is it?
Yes.
If it is a lymph node in the posterior triangle, which is more than one lymph node, as I can see, why does it have to be a metastasis or secondary? Can there be primary lymph node malignancies also?
Yes, sir. 15% chance of primary malignancy from the neck, sir.
What are they?
Branchial carcinoma, sir.
Well, we are talking about lymph node now. You think it is a lymph node, and now in the lymph node, what is the primary malignancy we are expecting?
Have you heard of lymphomas?
Yes, sir. No, Hodgkin's, non-Hodgkin's lymphoma, sir.
No. I first asked you simply lymphoma. They are the primary malignancies, no? So my request is don't come prepared with a scripted situation. It harms you more than anybody else because you're focused only on the diagnosis you have come prepared with. Any questions, Dr. Jayala and Dr. Rajiv Sai? We can otherwise move. Because I think that's a basis of why do you say it is lung?
Since cough is present for the 2 months and loss of weight is present, sir.
Okay.
Okay, Dr. Lavanya, let's get back to your script then. You think it's a clinically unknown primary,
Yes.
right? With secondaries in the neck. What do you mean by clinically unknown primary?
Patient presenting with symptoms at a metastatic site after thorough clinical examination and radiological examination, primary could not be made out, sir.
Okay.
But even clinically, you are suspecting it is from the lung.
No, sir.
You said no, it's from the lung because cough is there.
Maybe lung carcinoma or unknown primary, sir.
Okay. We take your word. Then what do you mean by occult primary? Can it be an occult primary?
Yes, sir.
What do you mean by occult primary?
Occult primary, when the primary tumor is could not be made out, even after clinical examination and radiological examination, since the tumor is slowly progressing or the tumor is involuted, the primary could not be made out, and only the
Doctor, please try to answer only the question. Otherwise, if you want to expose all your knowledge, it will be difficult.
You're rattling it out so easier. Occult means hidden. It is there, but you can't make out. Either anatomically hidden or physiologically. It is too small to get into your trap, or it is lying in sites where you can't reach. What are the hidden sites from where it can come? In head and neck?
From head and neck, posterior 1/3 of tongue, sir. Piriform sinus, fossa of Rosenmuller.
I'm giving you oxygen now. So therefore, you grabbed it quickly, answered it. What are the hidden sites in the upper GI?
Yeah, go on, Dr. Lavanya, rattle it off.
Upper GI.
You said Rosenmuller. Said piriform fossa.
You mentioned
posterior third of the tongue. What else?
Rosenmuller, crypts of the tonsil.
Yes, sir.
Piriform fossa, parapharyngeal spaces. That you mentioned. Right?
Yes.
So lower down. Fundus of stomach and in the colon, all the flexures and certain sites with J maneuver you will be able to pick up with a scopy. So we are not going there.
Okay, Dr. Lavanya, one question for you now.
Yes,
is it in the which lymph nodes are they? Are they in the upper half or in the lower half of the neck?
Situated in the middle, sir.
Okay. So
4 centimeters from the clavicle, sir.
Okay. So what is it likely, which is the area likely to be involved?
Hey, Dr. Sai, she's talked about based on history to be lungs. That's
okay. Okay, what kind of malignancy?
I'll qualify your question to her.
Right.
Asking you to basically be a Sherlock Holmes now, go back in time to pick up from where all it could have come here. Clear? Now, if it is in the upper part of the neck, what are the possible sites? If it is the lower part of the neck, what are the possible sites? And for God's sake, yours is in the middle. So you'll have to tell both of them. So if the nodes are in the upper part, what are the likely sites?
Yes, sir. If the node is present in the upper part, it may be from the oral cavity, sir.
You stopped. We didn't stop you. Carry on.
Yes, sir. Upper part, if the node is present in the upper part, it may be from the oral cavity,
Not right.
oropharynx or nasopharynx, sir.
Oh, you'll save time because otherwise we'll waste a lot of time. You loaded with theory, and you actually not using common sense, which happens very frequently. Don't mind it, Lavanya. Get your head out of clutter. Simple. Start from the head. Scalp.
Yes, sir.
Ear, nose, throat.
Scalp, ear, nose, throat.
Listen now. I'm answering for you. Now open the mouth. Start from front. Go backwards. From level 1 back to 5. That's how it goes.
Okay, sir. For level 1 node, now it may be from...
Yeah, no, forget it. We are not going there. You can read it. That's
okay, Dr. Lavanya, a better way would be that you just say above the clavicle, right?
Above the clavicle is neck nodes only, yeah. So that would be neck nodes only.
And
so
if it's lower down, it is... Now, how will you proceed in this patient? Let's come to that.
No, 1 minute. If it is over the clavicle, it is neck, no. So this is the unknown primary in the neck. You have an unknown primary in the neck, Lavanya. Correct?
Yes,
which GI problem you are anticipating, which can be silent and yet present. We have no primary history. Your cough is not persistent also. Now, how do you proceed? What can be the silent sites? We mentioned about the upper, you didn't mention about the lower. It is lying very close to the part where the sternomastoid is dividing into two, and it becomes a scalene triangle. So we are looking at GI also. So you took that history, you did mention about the examination. So what are the likely sites where it can be silent for a long time?
Colonic malignancies.
Colonic, yes. Even stomach.
Yes.
Mnemonic is loads for stomach. Lumps, obstructive features, anemia, asthenia, anorexia, early onset dyspepsia. And last is S, silent. Same thing applies to right-sided colonic malignancy. So you should be open-minded when you're approaching this. You will be asked questions pertaining to why it is a lymph node, what are its relationships, because you otherwise will be discussing all theory. Question that Dr. Sai asked you, how do you proceed? I wanted it to be in perspective so that now you can start from here. Approach, madam.
Yes, sir. In favor of diagnosis, I will do ultrasonogram of the neck, fine needle aspiration cytology, sir. In ultrasonogram neck, I will see whether it's benign or malignant or from where it is arising, sir.
I am sorry, I'm stopping you. Will it be unknown primary unless you've done ultrasound? That's one fundamental question Dr. Sai asked you.
Yes, sir. After clinical examination and radiological examination, the primary could not be made out. It is known as unknown primary, sir.
You've already done that. Why are you telling us to do it again?
You already made a diagnosis.
Yes, sir.
So you found nothing on clinical and radiological investigations. What is the next thing you're going to do?
Proceed with open biopsy, sir. Incisional or excisional biopsy, sir.
You won't do an FNA.
Okay. Hang on.
1 minute.
Why will you do an open biopsy?
1 minute, Dr. Sai, she'll get confused. You mentioned here ultrasound neck FNA. Pan endoscopic extract. You know, it is a classical situation of a surgeon putting the retractor on the patient and right angle forceps far away from him. It's all organized when you're talking. Imaging should be in one end, and you should be putting chest X-ray somewhere. It's all erratic. So investigations you would do to establish your diagnosis first. And you've done ultrasound neck. Will FNAC be done or you'll go for an open biopsy?
FNAC, sir.
Okay, so why won't you do an open biopsy? Let's come to that.
She won't do that. Let's not take her there. Would you do an open biopsy or you want to change it?
Proceed with fine needle aspiration cytology.
No. Answer your question. No, the question. Will you do an open biopsy or not?
If FNAC is inconclusive, we'll proceed with open biopsy.
No. You will still do. My question is, whether you will do an open biopsy or not. Not if FNS is there, not if ultrasound is showing something, not if anything else. The straightforward question, will you do an open biopsy or not?
No, sir.
Why not?
If it turns to
Because,
be
yeah,
if the node
go on.
turns to be positive, then radical neck dissection may be difficult, sir. Since
I think I'm
You-
getting
because
restless
so
there, Dr. I. Otherwise, she'll lose the plot. In the
okay.
neck, not only here,
You
nowhere you do excision biopsies. These days, it is an outdated procedure. Reason, we can do FNAC under ultrasound guidance and get our answer. Number two, we can add core biopsy and get the answer. Number three, if you don't get any answer, the minimum thing you do is dissection. You don't do biopsies of lymph nodes. Although I know histology is needed for making a diagnosis of lymphomas, etc., but FNA would generally be the. What is the algorithm for unknown primary? Let's not waste time. What is the algorithm? How does it start? You do an FNAC first, right?
yes, sir.
Tell you at least basic thing. What do you want to find out in FNAC?
Yeah. What is the objective of you doing FNAC?
To see whether it's squamous cell carcinoma, adenocarcinoma, or
Let's
any
talk.
undifferentiated carcinomas.
So it is squamous or adeno. Now, how does it change your algorithm further?
If it is squamous or adenocarcinoma,
I said squamous only. You can't be both, no?
okay, sir. Squamous cell carcinoma, it may be from the submandibular parotid or
Understanding is a problem. See, Lavanya, you've read it or you're reading it even now. That will
no,
go
sir.
by people who read and speak or those who read and ask if they have problems. Look, understand the basics of finding out. FNAC is not your first investigation in most situations, but in only unknown primary, where you don't have anything to start with. You do an FNA if it is squamous cell carcinoma, you look for all sites where there is squamous epithelium, common sense. If it is adenocarcinoma, you look for all places where there is adeno. And submandibular gland is adeno, not squamous.
Yes, sir.
So now answer the question. I want to take you there and so that you can take off.
If it turns to be squamous cell carcinoma,
yes, you do triple assessment or you do triple endoscopy. If it is adenocarcinoma, you do pan endoscopy. Let's cut it short. A triple endoscopy is what?
Laryngoscopy, bronchoscopy, and endoscopy, sir.
They're all endoscopies only.
OGD scopy, sir.
Yes, OGD means? Only upper, and
yes,
pan would be upper GI endoscopy and colonoscopy. So this is a standard algorithm. And you can do with core biopsies, and it's one thing about doing a core biopsy and getting a. Why do you need a tissue? Why not cells alone? Suppose everything is drawing still, you've done yes?
Immunohistochemistry, sir.
Very good, excellent. Why? That will take you to the source.
Yes, sir.
That's the whole approach. Is that clear?
Yes, sir.
About CT, head and neck. What about, why do you want to do that?
To see for any primaries.
You can again look for the primaries. And MRI, is it superior to CT or inferior to CT in this scenario?
Superior to CT, sir. Since soft tissue involvement can be.
So you're right. For the upper part, it is MRI. For the lower part, it is CT. And PET CT is one. This is one place where PET CT is useful because you have no primary detective.
Yes.
Immunohistochemistry by itself is not an investigation.
Yes,
Immunohistochemistry is part of your histopathology where you do additional tests to find it out. I don't know why do you want to do a sputum AFP now? You're doing it for cough, maybe, in your case. That is entirely your take. X-ray chest is useful. Nobody says it should not be done. But you follow an algorithm and be precise about it.
Yes,
and
you are expecting a lung pathology. And what type of FNAC you are expecting? Squamous or adeno?
Adenocarcinoma.
So you won't get the squamous carcinoma in the lung.
Squamous cell carcinoma or adenocarcinoma. Both may be possible, sir.
Both. Suppose your cells comes as undifferentiated. You are not able to differentiate by FNAC whether it is a squamous or adeno.
It comes
Can
to
it be
be
anything other than
undifferentiated.
squamous? Dr. Lavanya, can it be anything other than squamous or adeno?
And that would make your your Horner syndrome relevant, which is what you were trying to say. It be relevant. Now answer the question that Dr. Sai has asked you. I've just added, I've given you a hint. Please carry on.
Thyroid malignancy.
Anyway, you why you were asking something.
Sir?
Right. So it can be a melanoma and it can be a lymphoma, right?
Yes, sir.
So you have to keep in mind in all that and do your investigation. Okay. So now you've got suppose squamous. How do you proceed?
No, you've done triple endoscopy. You'll have to now get down to the point. You've done triple endoscopy now because after I told you the algorithm, I think you can understand that. So when you've done triple endoscopy, you found no primary.
Nothing found.
It just says, now what do you do next? That's how we can proceed. It is a squamous cell carcinoma.
Squamous cell carcinoma and primary could not be made out.
And your stage is N2A, right? That's what you've written.
Yes, sir. For N2A, since the node is mobile, we'll proceed with neck dissection and followed by radiotherapy, sir.
Okay, Dr. Lavanya, sorry. Any ethical issues related to this? Any ethical issues?
Please answer
managing,
that. I don't know.
Yeah. Look, managing the secondaries without getting the primary has got some ethical issues, right? Suppose the primary jumps out later on while during your course of treatment. So you will have to explain to the patient before proceeding that in spite of everything, we have not found the primary, but it can reveal itself anytime during course of treatment, right?
Right. Okay. So you've done a PET scan, and in most cases, you'll be able to pick up, except when it's too tiny, not secreting, that's not active, dormant, or it's in one of those hidden sites. Finally, not biopsy, never biopsy in the neck. And it's not for only the anatomical reasons. Even otherwise, it makes no sense at all. Because you will be distorting the planes for dissection later on, which makes it a hell. So you would be focused on doing neck dissection. It is the last resort. And neck dissection is done to find the primary again.
Yes.
Because
last resort to find your primary.
So it's a diagnostic neck dissection. Therefore, you don't do therapeutic. That is how you will explain it. And diagnostic neck dissections are selective neck dissections, only including areas where you suspect and you don't do any damage to the three structures: spinal accessory, jugular. So it is more of a select. These days, most the dissections are called as SNDs only, mentioning the levels you remove and the structures you preserve, and then you can get a histopathology and immunohistochemistry done to find out where possibly the primaries could be arising from. Clear? So there's like a biopsy in the node, but there are situations. You've done a core biopsy and it comes out to be a lymphoma. The pathologist may ask for a complete node. And in that case, you don't do a neck dissection. You can then take out a node, making sure that your incision falls in the plane, which you can utilize later on for neck dissection if you need to. It doesn't go from one to the other node just because you handle the node. But yes, lymphoma, you need a tissue for making a diagnosis. Can you tell us why? So now the question is out of your script, no? So you won't answer that. That's the problem.
Sir, lymphoma.
I'll be asking you questions relating to your clinical presentation. Lymph node, why not lymph node? I'm asking you about lymphoma, madam. I'm sorry if you didn't hear. Why do you need tissue rather than FNA for that?
Nodal, any breach is there, any extra nodal.
Do you know how you make a diagnosis of a lymphoma? You mentioned Hodgkin's and non-Hodgkin's.
Yes, sir. It's sent for histopathology, sir. After the.
Why not FNAC?
Biopsy, sir. After taking biopsy, they send for histopathology, sir.
I'm asking why. Why not FNAC? Why biopsy?
What additional information you get by taking a biopsy or a tissue? Then yes, cell.
How is biopsy different from FNAC
You can send
in
for
cytology?
immunohistochemistry, sir,
Dr.
from biopsy.
Jailal is asking a very, very pertinent question. Let her answer that. Why biopsy? Why not FNAC? And what additional information you will get to make a diagnosis of lymphoma when you're talking about when you do the biopsy? FNAC can't make a diagnosis of lymphoma. This you will read. We will not tell you because everything cannot be taught on a platter. You come prepared with set ideas of unknown primary and metastasis from unknown primary, then you'll get frozen in mind. You know the answer, so think about it. Get back to your basics in lymphoma.
Okay, Dr. Lavanya, I'll just take you back to one more question. You've done everything. You couldn't find the primary. Any other last ditch investigation you want to do before you go for treatment? Final court of appeal? Any last investigation? You've done everything. You couldn't find the primary. You'll have to do a tonsillectomy of this.
No. 1 minute. Sorry. No.
Brain biopsy has gone.
Like it happens in all classes. I am sorry. I have to stop you there. Now, this used to be a trend in the past. While you're doing neck dissection, you may do ipsilateral tonsillar biopsy, which is taking the crypts out, right? Be careful about it. You don't offhand do it, correct? It's similar to taking lavages or brushes from the stomach. So this is not routinely done. But when you're doing the neck dissection, they may ask you a question.
You'll have to remove.
Pertinent. That can you add something to the routine neck dissection? Even that is not done. Immunohistochemistry is really advanced now. You know, with a core biopsy, you'll be able to get the tissue of origin in most cases. When we were not getting it earlier, while doing neck dissection, we would take out the tonsillar biopsy. You don't do it now. And certainly not tonsillectomy. Please don't do that. And what he's trying to suggest is these are sites which you may miss otherwise. And when you're doing oral examination, there is an office procedure, which is a part of oral examination, that is indirect laryngoscopy, to look for those missed areas, the case of tongue you mentioned, and all all those that you mentioned. And you can get again primaries, like hidden primaries from, I've got it in many cases from adnexal tumors that Dr. Khanna was mentioning them earlier, from behind the ear, from in the scalp, small nevus. So examination has to be extremely careful. Melanoma in the lung is not common, but you can get it from skin anywhere. So head and neck needs to be examined extremely carefully. Any little tiny. And you know what? The moment you get the node and the pathologist gets it, she'll be or he'll be able to tell you, or a source is this. So you can scan again and go back. And it's not criminal to do a neck dissection to diagnose. But don't damage the patients, or don't bring down the quality of life. You know, neck dissection can be only as morbid as the biopsy that you talk about. Many times you get very bad scars. Through a small approach, you can do it. So I think unknown primary is a very extensive subject.
Just one last question, Dr. Lavanya. Is your case, is it a favorable case or an unfavorable case?
Unfavorable.
What are the points to show that this is a favorable or an unfavorable case?
Unfavorable case since the primary could not be made out, sir.
So in the cusp only, you are carrying a case like this. You have already making a diagnosis unknown primary. With that, your setup case, that is a decision, whether you consider it as a favorable or unfavorable.
Dr. Sai, you answer that, save time.
Right. So if, because your lump is less than 6, any lump which is more than 6 centimeters, multiple lymph nodes, not responding to your treatment.
The lymph node mass is less than 6 centimeters. That's what you're saying?
Yes.
N2A, not N3. So N3 has, it's N2. So you're suggesting that if it is N3, the prognosis would be bad. Is that what you're saying?
Yes.
There are many factors, you know, the primary would be adding to what Dr. Sai just mentioned. Your answer should be, I'm just trying to be on your side. In most situations, sir, it depends on what is this primary, what is the grade of the tumor, what is the nature of the tumor. There are so many variables to it. Correct? So with a lymphoma, the therapy is good, patient can do very well. So we don't know what is it. When we find out, only then can you define it. Simply by saying size alone doesn't matter here. It also
The
matters.
other factors, if it is an adenocarcinoma, the prognosis would be poor.
Yes,
right?
squamous does better than
Squamous, right.
It's correct.
Yeah.
And if
Suppose,
it is over, it will be even worse. You know why? So be open-minded in answering and always say that, because you're right in saying it. It depends on many factors. It cannot just be one thing you're observing and examining. You've got no primary to talk about. If you think it's a lung primary, is it early disease or late disease? Your diagnosis. You said primary is in the lung. So is it an early disease or a late disease?
Late disease.
So should that make it a bad prognosis anyway? The answer is yes.
Yes.
Why you hassle? You've done very well. Your history was good, your examination is good, but you were obsessed with one diagnosis, which happened in the previous case also. And that, I think, is a lesson you can take home. Be open-minded in answering questions and preparing your case. You don't have to stereotype all the time. Like in the middle of some complicated investigations, you mentioned AFB also. I'm not saying AFB is not necessary, but then you should have kept it as a differential. Tubercular. Because tuberculosis can mimic anything in our country. You know, the most common cause of nodes in the neck in the West is malignancy. In India, is still tuberculosis. And in older patients, more likely to be malignant, yes. But then it must not be always taken as one factor that you stick.
Suppose in this case, you have seen a small nodule in the breast and you are seeing the node. Will you call it as a nodal metastasis or metastasis?
Metastasis.
Now, again, I'm sorry, wonderful answer. You should ask him again. I mean, Dr. Jailal has asked a very pertinent question. Sir, which side breast?
Yeah.
Right? So always be open-minded in your asking. Supraclavicular nodes, this is not qualifying as supraclavicular. Supraclavicular node would be N3, but this would be M1, as he rightly mentioned. So,
M1.
Who asked that? In the
Go to the other side, it will be M1.
Anything
else? But still, you would have been much more open in your mind, thinking of a primary malignancy as a possibility also, because it's the age, all the things is also criteria. Because without any, straight away putting it as a secondary, you will be in a difficulty to face that.
Right. So thank you very much. It was a wonderful case presentation. We thoroughly enjoyed it. I hope you enjoyed it as much, unless there are more questions. And importantly, you're looking very tensed up in your presentation. So you ran through your presentation. Enjoy your presentation. There's nobody who is going to do anything with this presentation. You're definitely going to do well. But we could make out that you're basically already fixed on what you're going to say. So that can take away many common sense things that you can answer easily.
Yes.
Do you have a question?
Yes, sir.
Do you have a question to ask?
Answer for that question, sir. Hodgkin's lymphoma. We have to do.
No, that's not fair. How do you define lymphoma? When you look at the tissue or the slide, you taught. It's a histological diagnosis, and they talk in terms of some grading there. Talk about Reed-Sternberg cells, so many things.
Yes.
FNA cannot, at best, they can tell you there's a lymphatic tissue. Same thing like sarcoma. You can't make a diagnosis. It says mesenchymal tissue. You need to be looking at all those features. Lymphoma is always a histological diagnosis, not a cytological diagnosis. Cytology is when you study the cells. Histology is when you study the tissue. So naturally, biopsy will have more, less false negatives and less false positives.
Yes.
Can we close, Dr. Jailal, Dr. Sai? It's truly a joy always. Dr. Kanagavel, do you give us the permission to...
Kanagavel is there, sir?
I think it's too late for him to.
Professor Khanna would be there, sir.
It will be too early for Kanagavel.
Thank you so much. I think with that, we close it.
Yes, sir, please.
Dr. Kanagavel is there with his smile, so we can make out. Can we leave, sir?
Sir, I've been listening to you very actively. Sir, we normally allow the student to ask questions or doubts if there are any.
I asked her to ask questions. I did go by your protocol and I asked her. She asked me one question, I have answered.
No, sir, it's my turn to ask her. Please permit me to do that.
Please do that.
Lavanya and Joshiba,
Yes.
see, this is an opportunity to get clarified any of your doubts with the national examiners. So, having prepared for this exam, I'm sure you would have read more than 2-3 textbooks. I'm sure you would have had your own thoughts being challenged by reading more textual knowledge. Do you have any doubts to be clarified? Or at least after all the examiners ask you all the tough questions? You're already tired.
Read less, think more.
Relax.
That's
Fine.
where they answered that for you. Read less, think more. You read too much, think
Point
less.
very taken, sir. Well taken, sir. So, Dr. Senthil sir, Armagam sir is there, ma? He's still there. I saw his name joining sometime in between.
Yes.
Kamalini is there, I think.
Sir, Senthil sir?
Shandini madam is there.
Kamali madam joins for classes.
Shandini madam.
Yes, sir.
Shandini ma'am. Madam, would you like to give
I'm
up
there,
your
sir.
comments before we class?
Shandini ma'am, you have any question?
Fine. So I think we'll call it a day. And I personally, wholeheartedly thank all the faculty who have joined us for this evening. And special thanks to Chintamani sir and other invited faculty for the day. Sir, Chintamani sir, maybe I will request you to allot monthly one Friday for us for this purpose. So I leave it to your comfort, whichever day you are free, please indicate us. I will be happy to have you amidst us. Thank Sahay sir, Jailal sir, Narendra Gupta sir, Ajay Khanna sir. I could see Professor Mukesh Vera, Professor Narendra Gupta, and other senior faculty. Thanks for joining. Thank you, Joshiba, and thank you, Lavanya, for sharing your valuable time. And I thank Dr. Pabita Devi from Tirunelveli
Thank you,
Medical
sir.
College.
Thank you, sir.
Thank you, ma'am. And then I thank Dr. Srinivasan, sir, for permitting both the postgraduates to present a case here. Friends, and we will meet in the coming Friday with yet another fresh case for discussion. Thank you very much. With the permission of the faculty, I'll call the session